Today's lecture is going to be over abdominal trauma. We talked about chest trauma, and one of the things we alluded to, we talked about chest trauma, is any low chest trauma is always to be assumed to have an abdominal component to it as well, as the diaphragm separates the thoracic cavity from the abdominal cavity. With abdominal trauma here, we see a picture here of a gentleman with appears to be a simulated abdominal evisceration. Evisceration is where you have intestines on the outside of the body versus the inside, as shown in this photo here. This guy appears to be a very cooperative participant for having such an injury, so I'm assuming it is staged as well. So the objectives, we're going to look at some basic anatomy of the abdomen. The big important things, not that it's not all important, is to understand that within the abdominal cavity you have solid organs and hollow organs. Solid organs, when ruptured or insulted, will bleed and induce shock pretty quick. Hollow organs will spill their content, and you could become shocky from it, but more than likely those patients have issues with sepsis related to abdominal contents as time goes on, if not discovered in a good amount of time. So we're talking about blunt and penetrating injuries as we did with the other trauma sections, and we're going to just talk about the treatment for the patient with the protruding viscera or protruding inner parts. Okay, we're going to look at how to stabilize a pelvic fracture and why it's important. It's important to stabilize a pelvic fracture because you could lose almost your entire circulating blood volume in your pelvis. You could bleed to death in your pelvis. You could lose the majority of your blood volume in bilateral femur fractures. You could bleed to death in your retroperitoneal space. And you also bleed in the abdomen, the chest, and the head. But the pelvis kind of goes unrecognized because we're so used to dealing with like broken hips and things like that on a day-to-day basis. But a pelvic fracture, pelvis is very vascular, and any type of pelvic fracture can insult those arteries and deep veins and lead to uncontrollable hemorrhage. Okay, also we're going to look at findings indicating possible intra-abdominal injuries based on history physical exam. Generally, if it hurts, there's something wrong. Okay, so we want to look for different types of signs, and we'll talk about those. And then we'll talk about critical interventions. Obviously, for the abdominal issues, trauma is generally considered a surgeon's disease. There's not much we could do for that in the field. So quick evaluation, expeditious loading and transporting could make the difference between a favorable outcome and a not so favorable outcome. If there's hemorrhage, you should anticipate shock. Remember, by the time the blood pressure drops, you've already gone from compensated, decompensated to shock. Okay, infection. Is there gross contamination, whether that be from internal organs, hollow organs spilling their contents, or it could be an open abdominal issue that has all types of contaminants in it. So we always have all these concerns with this. Okay, if you look at the anatomy of abdomen there, one important thing to note is our diaphragm. Our diaphragm is a muscular structure that separates the thoracic cavity from the abdominal cavity. It's one of the main things that supports breathing. The diaphragm has to drop, chest wall has to go out, and neck muscles pull the chest wall up. Air comes in through negative pressure, we've talked about several times. One thing that's important to note is we have this organ here, the spleen. The spleen is a little organ. When lacerated, it does bleed. It's a solid organ. Here, if we look at how large the liver is, compared to a lot of the other organs, and then we see our pancreas and our kidneys. These are all major solid organs, okay, which tend to bleed when ruptured. Okay, if we look over here, we have our intestines. We have our duodenum, our small intestine, large intestine, our urinary bladder. Urinary bladder tends to get ruptured with some pelvic fractures, and hematuria is a prominent sign of that, which is bleed blood in the urine. When you look at the cross section here, you'll notice here your kidneys, and your left kidney, your right kidney, sits in a retroperitoneal space. This is your peritoneal space here. The retroperitoneal space sits right behind there. And if you look at the amount of surface area in the retroperitoneal space, you'll see that the kidneys being solid vascular organs, that you can lose a lot of blood in this area. And one of the issues is that once we mobilize someone or do spinal motion restriction, we place these people on their back. And so when we go to put someone on a board, we need to look down their back for bruising, any type of contusions, any type of lacerations, penetrations, anything like that. Because once we put them on our back, it'll be very difficult to assess. You should always suspect a kidney injury on any type of shearing injury. Also, any type of blunt trauma to the back. Obviously, penetrating trauma is kind of a sure thing, but you should always be very cognizant of that. Now, see here cross section, your liver, your aorta, and the aorta is a very strong vessel. However, it is also a very vulnerable vessel for lacerations. And our stomach here, contains all of our gastric contents and food, and it always seems like when people are in traumas after they've had a big dinner of beer and spaghetti. So depending on how much stuff they've eaten, it'll determine how much is in their intestines and their stomach. And depending on where they're wearing their seatbelt, you can see where there be some intestinal damage or other issues. The abdominal regional injury, thoracic region, life-threatening hemorrhage. The liver is very vascular, and so is your spleen. Splenic injuries, sometimes they encapsulate, meaning that they close off by themselves, and a lot of times they're observed over days, unless the patient's shocky. Liver issues. The liver is very, very vascular, and not a whole lot of liver lacerations are allowed to sit idle. Most of those go straight to surgery. The true abdomen, we worry about infection, peritonitis, which is inflammation of the peritoneum, shock from volume loss, could be shock from volume loss or blood loss, our intestines, severe hemorrhage. Our retroperitoneal abdomen is also known as a retroperitoneal space, and it's hidden, big vessels, and our kidneys are back there. More important than the major vessels, our kidneys are back there. Very important thing. Okay, blunt trauma, mortality is 10 to 30%. Penetrating trauma, gunshot wounds, stabbings, anywhere from 1 to 15%, depending on that. The big concern is the bleeding in the abdomen with hemorrhagic shock and secondary sepsis or peritonitis. Generally, you get peritonitis prior to getting septic. It just depends. Peritonitis, like says, inflammation. Sepsis is a systemic infection. So when you do your scene size up, we look for things like that. So when we walk up and we see this, let's say your person is walking around. People occasionally get out of these cars and walk around. Things we should be looking at. One is airbag deployed. And remember, the airbag deploys a force this way, but you're decelerating that way if it's a frontal collision. So the organs inside your body are still traveling at that same speed. Therefore, when you abruptly stop by the airbag, your internal organs are still going as fast until that is stopped. So you could end up with significant abdominal trauma even in the presence of airbags opening. We see here the windshield is broken. It makes me wonder if this was a severe crash or this was extrication, because the door's gone and the window's broken up. But we see here, we have damage to the console and different things like that. So if this was not an extrication picture, which is hard to determine what it was, just by looking at the fact the airbag opened up, we want to determine whether patient's restrained or unrestrained. Unrestrained patients tend to have a higher index of suspicion for injury than people who are restrained. But people who are unrestrained tend to have more external trauma, because in a frontal collision, they'll either go up and over the steering wheel or they'll go down and under, is where you find them. So you either end up with head and chest and abdominal injuries, or they end up with really severe leg fractures, whether it be tibia, fibula, or femur. Okay. Mechanism, direct compression of the abdomen. Okay, fracture solid organs. Solid organs bleed. I know I say that redundancy, and you guys are probably sitting out there rolling your eyes every time I say it, but I promise you when you take your test, you're going to say solid organs, do they bleed or do they spill? They bleed. Okay, spleen and liver. Blowout of hollow organs, such as your intestines. It could be your gallbladder, which holds bile. It could be your intestines. It could be your stomach. Any of those hollow organs. Also, through deceleration, you can get tearing of organs and blood vessels, especially if you don't have damage to your kidneys. You can have damage to the renal arteries that provide the blood source for the kidneys, which can cause a very severe hemorrhage. Also, accompanying injuries, very few people have just severe abdominal injury unless it's a stabbing or gunshot, something like that. Most of the time they have head, chest, or extremity. 70% of motor vehicle collision victims have some form of blunt abdominal injury, whether it be mild or severe. Penetrating abdominal injury, direct trauma to the organ or vasculature, so a projectile or fragments. One thing to remember about projectiles, a projectile doesn't necessarily, we assume that a projectile was a bullet, but a projectile could be anything coming from the outside through the inside. For instance, someone can have a tree limb go through them, okay? That could be a projectile, something projected upon you. But generally think of projectiles being bullets. And bullets are designed to do a couple different things. Bullets are either designed to enter the body and break up, or they're designed to stay pretty much intact and punch a hole through. Granted, there are all types of I guess, quote unquote, luxury bullets that do all types of different things. You have tracer rounds, which produce flame and different things like that. But one thing to remember is, one, it's hard to delineate an entrance wound and an exit wound when it comes to bullets. Two, a bullet doesn't have a mind of itself. So depending on the velocity and the distance the person is from said weapon will determine how much that bullet traveled, whether a bullet tumbled. Did it have cavitation? Cavitation is a creation of a cavity upon the entrance of a bullet. So these are all things to think about. So even a small bullet hole in the front and a small bullet hole in the back, there could be severe trauma in between. And nothing says that a bullet that enters the abdomen is going to come out of the abdomen or even come out at all. So we always need to be cognizant excuse me, of other injuries that could be associated. One thing you need to do is be very cautious, okay? Vigorous fluid resuscitation may do more harm. Generally, think of fluid resuscitation as standard 20 milliliters per kilo or 20 cc's per kilo of crystalloids. We all know that crystalloids, we carry normal saline lactated ringers. And crystalloids are crystal clear. They have no oxygen carrying capacity, whereas colloids, blood or blood products, does. So, we need to be very, very careful, because the body has a normal protective mechanism. We have the clotting cascade, and the body's going to try to fix itself. And the more we volume resuscitate, the more likely we are to thin their blood, decrease their oxygen carrying capacity, destroy that clotting cascade, and ultimately cause them to bleed out. So we want to be very, very careful. It used to be many, many years ago, you start 2 large bore IVs and you just start dumping fluid in these people. And after a lot of studies, it's just not a beneficial thing. Those patients have poorer outcomes. Sometimes they do need some volume to assist with the pressure, good enough to maintain your cerebral perfusion pressure, but generally should maintain like a permissive hypotensive state. Anywhere they say 80 to 100, generally you're safe to maintain right around 90. 80 is getting a little bit low, but you want to gauge it on cerebral perfusion, how well they're doing, what's their overall hemodynamics. If someone has a blood pressure systolic of 90 and their heart rate is 80, then they're doing well with the volume resuscitation. If their heart rate is 80 and if their heart rate's like 150 and their pressure is 80, then that is significant shock. So we need to get the patient somewhere as quickly as possible, and not someplace that could fix the injury, not someplace that could just receive the patient and transfer them other places. PASG, which is pneumatic anti-shock garment, or also known as MAST, M-A-S-T, military anti-shock trousers. They're not commonly seen on the ambulance. They're not mandatory equipment in most areas. We do have some pairs in the training center if you ever want to play with them. But These were created widespread in the Vietnam conflict, where the premise on them is they put them around the patient's lower extremities and the abdomen, and the three compartments are inflated with air, and it will in turn shunt the blood from the lower extremities to the upper body to help the body maintain a better state of perfusion for the brain and vital organs. But they've come to the conclusion that even though it is somewhat helpful for shock, in the long run, depending on where the patient is injured, it can actually make bleeding more rapidly and actually make them do worse. Pneumatic anti-shock garments, they have some limitations. One, if someone is pregnant, you can put them on. However, you only inflate the legs and not the abdomen. If someone has any type of abdominal trauma, you inflate the legs and not the abdomen. But generally, they shouldn't be considered much with any type of abdominal or chest trauma. One thing they are very useful for, and they are used in the coal mines quite frequently by their first responders, is pneumatic anti-shock garments are very good for stabilizing multiple long bone fractures, because they're basically a big air splint at that point in time. So if you're in a big hurry with other major trauma, that might be a means of just stabilizing those lower extremities. But generally, airway, breathing, and circulatory issues are the top concerns, and most long bone injuries tend to be more distracting injuries, even though you can lose a considerable amount of blood by a femur fracture, and not to mention a vascular injury, especially a high extremity issue where the patient would need what's known as a junctional tourniquet, so bleeding like from the groin area or from an amputated leg where it's really high up in there. Junctional tourniquets haven't made their way to civilian practice a whole lot, and the military has some. However, they're used more in the field hospitals than the actual field, as they're somewhat difficult to deploy and are not readily available out there. A couple of the veterans in our class could probably outline that a little bit more by seeing them in use, if they've seen them in use. So, but that's what pneumatic anti-shock garments. Remember, PASG is pneumatic pneumatic anti-shock garment. MAST is military anti-shock garment, or military anti-shock trousers for MAST. It's the same thing. Okay, projectile pathway, not very obvious all the time. Okay, if you suspect abdominal injury, as a chest is abdominal. So if it's right there on the border, it affects both until proven otherwise. There may be gluteal issues in 50% of significant injuries. So I guess what goes in the abdomen will come out of the keister, I guess, is what they're alluding to. Excuse me. And, depending on the damage to the old gluteus maximus, will determine how much bleeding they have there. But generally, I don't know why they feel that that's majorly significant. Granted, 50% is half, but glute issues are very, very rarely life-threatening. So, primary survey, abdomen, the whole DCAP, BTLS stuff, you know how much I hate mnemonics, with the exception of high sal for the ones from our class, obviously. But we have the deformity. So does something look out of the ordinary? Is there contusion, meaning bruising? Is there abrasions, which is scuffing of the skin, basically, road rash? Are there punctures or penetrations, some entering from the outside inside? Are they eviscerated, meaning are the insides hanging out? Is there distension, meaning is their belly protruding? Is there tenderness when you touch them? When you palpate the abdomen and you elicit a painful response, there's no reason to palpate that again. So just denote it and then move on with that. If you ever feel a pulse in the abdomen, you should suspect that it's a aortic aneurysm of sorts, and definitely rapid transport and don't push on it anymore. Splenic injury or spleen might refer to left back shoulder pain. So why that is something that's important to know is, let's say a driver of a car, has that seatbelt abrasion going across their chest. And where does that seatbelt come across? It comes across the right side, it comes across the left side of the body. So if they're having left posterior shoulder pain, don't rule it out as a seatbelt injury, they could very easily have a spleen injury. Okay. A liver injury tends to refer or direct pain to the right posterior shoulder. You can get severe hemorrhage of both of them. The bellies will get distended, will get tender, rigid. The belly will get taut. Pelvic tenderness or bony crepitation. Crepitation means you feel bones rubbing together is what crepitation is. Okay. So stabilization, signs usually do not appear early with abdominal. So they might have a little bit of pain, but always transport these people to hospital. If they're refusing care, we have obligation as cognizant responders to make sure the patients understand the risks associated with refusing. They must be alert and oriented to person, place, time, and event, and have the ability to comprehend what you're saying to them. So they have to be very much reliable. If the present injury is significant, always look for shock. And you should generally look for shock. We were doing trauma, and we know shock was a widespread state of inadequate tissue perfusion. So we want to look for shock early. Early signs of shock is tachypnea. Okay, so they'll breathe fast. They'll be tachycardic, so their heart rate will be fast, and their blood pressure might be normal to a little bit elevated. They'll have some anxiety to them, things like that. But that is early signs of shock. Once the blood pressure has dropped, that patient has progressed from compensated to decompensated shock. Very important point to know. Not just for tests, but for everything. So don't assume that someone's heart rate is fast just because they're worked up because they crashed their car. Okay? We can only know what we can assess. And we can only see, feel, or hear what we can see, feel, or hear. Okay? So, always err on the side of caution and be very proactive. And you always have to try to think a couple steps ahead with these abdominal trauma patients. Okay? Evisceration. If something is hanging out, do not push it back in. Okay? You want to cover with moistened gauze to keep the intestines from drying out, and then you want to put dry over the top. Okay? So put moist over the part and then dry over the top. Okay? Impaled objects, so don't remove, okay? If they have some kind of uncontrollable hemorrhage, there's very few uncontrollable hemorrhages out there, but if it's an extremity issue, don't be afraid to put tourniquets on early. Okay, tourniquets are it's kind of a different school of thought these days, which is a good thing for our profession, that get the bleeding stopped, then figure it out, versus messing around with pressure points and elevation and direct pressure and all that stuff for major hemorrhages. Okay, you want to stabilize the object, avoid movement, and make sure it's something that you can safely transport. If you have a patient, with a 3-foot piece of rebar through their abdomen, and you're working out of a little bitty van ambulance with a side-mounted cot, will you be able to transport that patient in your ambulance? So they may require resources you don't have, or you might need to call in extrication to modify this impaled objects in some form or fashion. So, areas of current study, things that people are looking at in trauma. One is destination protocols. Trauma, just like STEMI, like everything else, everything is very much a specialty center. But trauma is one of those areas where they definitely benefit from a trauma center. Serum lactate levels is another thing that people are studying. And a lot of times serum lactate levels are generally checked when you're looking for sepsis. A fast exam is done through ultrasound, and you're basically looking for internal bleeding or any type of abnormality of internal structure. Tranexamic acid, TXA, is used in our region. It's not used in our system as of yet. But TXA is the exact opposite of TPA. TPA is a fibrinolytic, which means it breaks up fibrin, it breaks up clots. Tranexamic acid, or TXA, is used to promote fibrin and promote clotting. So it's used exact opposite. It's very common. It's used in a lot of places in the world. It's generally recommended in uncontrolled bleeding, and Like I said, it's a really, really good thing. However, you know, there's definitely a time and a place for it. So intra-abdominal injury, you have to recognize, you have to find it. A lot of times, we always find the grotesque ones, parts hanging out or bullets going in or things sticking out, whatever. But, something as simple as noting contusions to the abdomen, contusions to the retroperitoneal space, you know, bruising around the belly button, bruising on the flanks, your whole colon sign, your gray Turner sign. All these things we want to look for. Early recognition of shock. Start giving them that fluid boost when they're just a little bit tachycardic and a little bit tachypnic. Okay, and minimize delays. So don't waste a whole lot of time with these people. Get them going, identify life threats, and get them to a hospital. And notify the receiving center as quickly as possible. So it is a trauma center. They can use some form of trauma alert and have their team assembled prior to you getting there. So this concludes abdominal trauma. If you look at the PowerPoints for your book, which I highly recommend you reading as well, you'll find that they basically take all these little PowerPoints I've been using and they combine them into several very long chapters. But if you run across anything that you have questions about or you don't feel that stressed, please send me an email, give me a call, send me a text, post something to our Facebook group, ask questions. I highly promote that. I'll never have a paramedic class that ever accuses me of not asking if you have questions. So take me up on it. If I don't know the answer, I'll definitely get it for you. And you guys have a good night.